So you just came from talking to the president, I understand. So I know that the Global Affairs Council of Atlanta is incredibly important, but I guess President Biden trumps that by a little bit. What did the president want to talk about?
We do briefings with him intermittently. So this was a briefing, it just ran a bit over.
Yeah, great, good. Well, we are obviously thrilled to have you, and also very thrilled that President Biden is taking the interest that he is in the whole response. And I want to ask you a bit about CDC, its role, the mandates, how things are facing, but just to start a bit back, as CDC is my ancestral career home, and CDC has had some ups and downs in this whole pandemic and the response, and I think you've come on and really looked at ways to build back the confidence in CDC, because I think having the agency responsible for prevention and the vaccine response, it is incredibly important to have that kind of trust. So just say a bit about what it is like and what you're trying to do, not only in terms of the response itself, but building back the confidence in CDC as an agency, and giving people a bit of a feel for, they read the headlines about CDC and I think don't appreciate the incredible institutional depth that there is around these things. So maybe just a bit about, yeah.
First of all, I'm delighted to be here. Thank you. And maybe I'll just respond to that by saying it's been extraordinary 4 months for me. It's truly an honor to be leading this agency. I certainly knew people at CDC before coming, but to have this incredible cohort of subject matter experts, of scientists who are working in everything from the response to infectious and non-infectious and outreach and global. It's just been, when I need an expert, there is one at my fingertips on any given topic. Part of what I've had to do really is to ensure not only the scientists of the CDC that their voice was going to matter, that their voice was going to be the one that was heard, that I was going to be relying on them. So I had to do have had to do a lot of work internally, and then a lot of work externally to say, actually, this is the science upon which these decisions are getting made and upon which these guidelines are being put forward. And so it's really been both internally facing and externally facing. I'm so grateful to Dr. Ann Schuckett, who has done an overview of the guidances in COVID for me to say, these are really the ones that need to be updated. These are the ones that need to be taken down. We did that early for a clean slate to just make sure that what was speaking was what the CDC voice was, the scientific voice that needed to be heard.
And so and I'm going to talk a bit more about what's going on in the U.S., but this is the Global Affairs Council, and CDC also plays a very important global role. Could you talk a bit about how you see your role from a global perspective and CDC's contribution to that, and then we can talk more about what's going on here in the United States?
I think that we have to play a role globally. I think it's a humanitarian need, but I also think that if we're going to protect the public health, even if you didn't have the humanitarian need at heart, if you're going to protect the public health of this country, you need to protect the public health of the world. I think WHO has said no one is safe until everyone is safe. And if you look at what the last 4 infectious threats were in our country between H1N1 and Ebola and Zika and COVID, all of them were had international roots. And so we really do need to make sure that we are protecting not only ourselves, but protecting the world. It's truly been extraordinary for me to see we're working in 60 different countries. And when India was starting to surge, we had 20 years of country office there. We have over the last year trained 14,000 infection control preventionists in India before the surge. And so when there was this surge, we were rapidly there to say, what can we do? How can we help? Similarly, in Brazil, folks on the ground going to say, how can we address this outbreak that is happening here? How can we understand the variants that are happening here? And so I really do think that that integration and collaboration across the globe is what has allowed those this to be possible. We can't expect to go into any given country and expect trust, collaboration, scientific integration unless we have those ties. And that, I think, is so important to the work that we do at CDC.
Yeah, and just before you came on, John and Kangasan, who heads CDC Africa, was speaking, and I think people don't really recognize, how global CDC is, and obviously going back to the smallpox eradication campaign, but particularly under HIV and AIDS, CDC's presence really expanded globally, and I think it just shows how important that being on the ground, the preparedness, those long-term relationships really matter. So maybe just a bit about how things are evolving here. It's been incredible how rapidly we've been able to scale up vaccines from, such a low baseline, and particularly a vaccine that is primarily, or at least initially, was primarily focused on adults. We didn't have the same kind of infrastructure necessarily that we do for childhood vaccination. So, I mean, this has been an incredible accomplishment, I think, but it is slowing down. And I think there's real concern about whether or not we will be able to continue to make the progress moving forward. So how are you thinking about where we are, both, giving ourselves and yourselves, the credit that is deserved for what has occurred, but where we are, where the challenges are, and how you're thinking about approaching, what seems to be slowing and perhaps the hardest populations to reach from here on out?
Yeah, so first of all, I think, we have the majority of adult Americans vaccinated. One dose has been given to 167 million people really in the last 5 or 6 months, which is really incredible. 135 million people are in this country have been fully vaccinated. So we should take a moment and celebrate some of those successes and the hard work it has taken to get there. At the same time, we always knew we would reach the inflection point that you have talked about, which is we are going to ultimately have more vaccine than we have people running to get it. And so then the question is, how is it that we do the hard work? There was hard work in the first phase, and now we have a different kind of hard work. And we have to embrace every single vaccine we get into someone's arm, that each one of these is critically important to our mission. I think we have to meet people where they are. And I know we've been saying that. I'm going to go back to what you said about HIV. When I was taught how to give a new HIV diagnosis as an ID fellow, a very wise social worker said to me, you tell a person they have HIV and then you wait and you listen until they say something first. And generally that first thing that is said is what's most important to them. What of all the menu of things that you feel like are important to you to deliver, what's most important to them to hear? What are they most worried about? And I feel like those same messages are very true of vaccine hesitancy, because some of it could be, I don't have childcare, or when am I going to do this in my 2-job day? Some of it may be, wow, that science seems like it went awfully fast. Some of it may be like, I don't have the day to have side effects tomorrow. So the real question is, what are the things that are getting in people's way in terms of, and I've heard stories of, Gwinnett County that's trying to vaccinate their schools, 30,000 people in their schools, which is just amazing. I was in Dalton County a week and a half ago, and they're doing 4 a.m. vaccinations at changes of shift and some of the run companies. So and it's working. And it may not be that it's worked the first day you see somebody or the second, but the third day, someone might say, okay, I'm ready to be vaccinated. So really, that's going to be the hard work. And it's not going to be in the, millions per county. It's going to be in the 1 by 1. And that's what we have to do.
And are we set up to do that? And what can we learn from other efforts?
I think we've had to be flexible in our setup all along the way. So is this going to be the mass vaccination sites that we set up in the beginning? No, it's not. It's now going to be the mobile units. And is this going to be at the central locations? No, it's going to be at the distal rural sites. Is this going, now we have to think about vaccinating people who are inpatients, who may be inpatients and ready for discharge. So I think we are evolving our strategies, even our communication strategy. How are we now reaching the young people? We have reached over 80% of our older people. How is it that we now take those messages and deliver them to the 20-year-olds who feel like they're, have no risk of getting sick at all? And so really we have had to pivot and morph our messages all throughout this, and morph our strategy all throughout this.
And so in order to be successful, I think it does take the kind of comprehensive approach that you've talked about. And, I think there's a real concern that everybody expresses, the race between the vaccine and the variants. How are you thinking about where we are in terms of variants? How much does that go into your factoring in, the speed? And then I also want to talk about speed versus equity, but talk about the vaccines and the variants and where you see that race between vaccines and the variants.
Right. So first to understand is where we are with regard to variants. And that is when I started on June 20th, we were as a country sequencing somewhere between 250 and 3,000 samples per week. Keep in mind, this was a time that we had somewhere around 250,000 cases a day. So really, we did not have our arms around what variants were circulating in the United States. Today, we're sequencing somewhere between 25,000 and 30,000 samples a week. And that is somewhere around 20% of all circulating virus. So we have a really good idea of the virus that's circulating here. And it's really geographically, we have our fingers geographically, so we understand where it's circulating across the country. We're keeping an eye on numerous variants. The B117 or the UK variant, or now renamed the Alpha variant. So that is now the virus that's most commonly circulating here in the United States. And it's about 74% of our samples. As we look at the variants, we think about three things. How transmissible are they? How do they respond to our drugs and our prevention strategies, like our vaccines? And are they more lethal? Do they hurt you more? So far, the vaccines that we're using here in the United States look like they have really good efficacy, prevention efficacy against the variants that we know about. So the UK variant, the South Africa variant, the Brazil variant, the new India variants. The vaccines that we have look like in the lab and in people, they're working against the variants we have here in the United States. There's always a concern that if the more virus that is circulating across the globe, that a variant could emerge that doesn't work as well, that our vaccines don't work as well against. And that's really the component of no one is safe until everyone is safe.
And so back to the issues of speed and equity. I think you have been very clear about the importance of thinking about vaccines and vaccination access from an equity lens, both here in this country, but also globally. How big of a tension is that, and how have you been able to, as an agency, really get that message across, the importance of equity?
It's been easy to sort of say this is important, and there's never been a challenge at all across the administration that we have to focus on it. Executing it has not been easy, and part of that is because, for example, we worked closely with FEMA to put our mass vaccination sites in places that had high social vulnerability index. We selected them as such. But oftentimes when there was vaccine scarcity, people would be crowded out. Those who had resources would find out first about them before people who had less resources. I think somebody told me that they'd never seen some of the pharmacies in their low or their high SVI areas so white. because it had been crowded out. And so executing it, we put them in the right places, but what would happen is that they'd be crowded out by people who had the luxury of being up all night to refresh their internet to find out where the vaccine might be. That has gotten way better over time. And so what we have done in collaboration with FEMA, we put our mass vaccination sites in collaboration with HRSA. We've been able to put vaccine in federally qualified healthcare centers. So we've been able to access rural areas, non-English areas, migrant farmers, those kinds of places. We've been putting vaccine in pharmacies, and pharmacies selected specifically because they serve a high SVI area. I think our pharmacy program hit over 47% of people who were non-white getting vaccine just in the last couple of weeks. So we really have, with more vaccine now, the crowding out issue has made that a little bit easier. We've made great strides in that area.
And then if you think about equity from a global perspective, besides the obvious that no one is safe until everyone is safe, and that, in a global pandemic, we have to be thinking about making sure that vaccines get to the rest of the world, it's also an equity argument. I think because this has had such an impact on the US population, we have not really necessarily thought as much about our responsibility to the global pandemic. So how are you thinking about it? What's the best argument? And do you think the United States should be doing more to be able to help with vaccines around the world?
I want to assure you that all of us have our eyes on this. It is the case to this day that the United States has had the most deaths from anywhere around the world. So there was a component of we needed to put on our own oxygen mask before we were able to help others. And now we're able to breathe again, right? So what we really need to do is share surplus of vaccines, increase our vaccine manufacturing here so that we can ramp it up so that we're able to help, and then increase the capacity to do vaccine manufacturing around the world. So not just so that we are teaching to or giving fish away, but rather teaching to fish, right? Giving capacity, we're creating capacity. So we have secured enough vaccine supply for the United States to be able to share 80 million doses by the end of June. That's 4 times the amount of doses of other countries. And we really want to be not only sharing the doses, but setting the example that other countries need to be able to step in. The other thing I think probably is worth noting is, especially at a time when there are surges or unexpected surges in other countries, and this gets back to sort of where we can help, a lot of times what they need is not only vaccine. So countries will need technical assistance, technical support, oxygen, other things. And truly, even in the vaccine, and this is sort of wearing my CDC hat, but even in vaccine delivery, we have had to say, how do you set up vaccine safety protocols? How do you set up immunization strategies when you're trying to immunize a whole country? And so we're working to do not just provide the vaccine, but in cases where they need it, provide the technical support, the support against vaccine hesitancy, and all the things that we've faced here.
Yeah, and while CDC does have clearly a global mandate, it really is the WHO that needs to lead this effort. And WHO is also an organization that has had a challenge with trust. Are there things that you think we could be doing to reestablish the role of WHO and build the kind of trust so that it can lead as the global public health agency that we really need at times like this?
I think you're absolutely right. I think we will all benefit from a strong, healthy WHO. Obviously, on the very first day of his presidency, President Biden's administration re-engaged with the WHO. I think that sends an extraordinarily strong message. We're here, we are with you. We've had long-standing collaborations with the CDC at the WHO, and we have been partnering with them. And we have to work alongside them in those partnerships as public health agencies, non-governmental organizations, ministries, to make sure that the WHO is strong so that we can all work collaboratively together.
Mhm. Right before you came on, Heidi Larson, who does a lot of work around vaccine confidence, we were starting to talk about some of the misinformation, and they are now doing kind of longitudinal work to really look at this. We all know that there have been people who have not had confidence in vaccine science for a long time, the quote anti-vaxxers, what have you. But how much of a role do you think that vaccine misinformation is playing into vaccine hesitancy? And what are the ways in which you're thinking about it from an agency to really counter some of that?
First of all, thank you to Heidi for all of the great work that she is doing, because we need people out there like her
Yes,
to help.
yes.
I think we're in an unfortunate situation with this with regard to how quickly mis and disinformation works along social media, right? It can infiltrate, and in fact, so much so in how it's done through social media platforms. We have the hard work of countering that. We do know that in all of vaccine administration, that there are going to be a small cohort of people who will not want to be vaccinated. Regardless of what we do, regardless of how we send those messages. And so what we really do need to focus on is countering the mis and disinformation that is out there through trusted channels, through trusted people. It may not be me they want to hear from. And I heard this in Dalton. You can send the National Guard, but we don't know the National Guard. We want to hear it from my firemen. I've seen him in church, and I want to hear from my firemen. So that's the work that we have to do. The mis and disinformation we are going to need to counter. I get questions all the time about infertility. Somebody planted that seed, and it just grew, but there's no truth to it. And so, those are the things that we just need to be out there and provide the tools and the science to say, there's no biologic plausibility here. Here's what we know, and then send that message to the trusted messengers. We do at CDC have vaccine confidence consults. If you're trying to understand, somebody asked me this question and I don't know how to convey it back with science. We have toolkits for faith-based organizations. So we have lots of tools that people can use to assist.
So I'm going to ask a couple more questions and then send you back to running your agency. But just kind of thinking about looking into the future a bit. I think there's a lot of concern about, is there seasonality? Is, after the summer or even during the summer in some places where people are more likely to spend summer indoors because it's hot and they go into air conditioning places, et cetera. What's your thinking about the likelihood that there is seasonality to this, and how should we be thinking about what this looks like down the line? And I know you don't have a crystal ball and we don't know everything, but just kind of your thoughts about it. And then two, the issue of boosters, and how should we be thinking about that, because that has been an impediment for some people, thinking that if they've got to get a booster, why bother to begin with? So just kind of looking a bit down the future, seasonality, need for boosters, some of those sort of things.
So in terms of seasonality, we certainly did see a summer surge in areas last year where people were indoors, and the hot states, and then this winter surge after travel. Coronaviruses themselves tend to have seasonality. We do know respiratory viruses tend to like the winter months better. I am really hopeful that we will have vaccinated enough of the country that we won't see these large spikes, barring any challenges associated with variants. But in addition to the seasonality, what concerns me is the heterogeneity of where we are across the country, because this virus is going to be an opportunist. And it may not go to places in California that are 70% vaccinated, but it may well go to places in Georgia that are 20% vaccinated. And these are preventable sicknesses and deaths. And so what I really want to do is try and see if we can blanket as much vaccine to places that are under vaccinated, so that when should this rear its ugly head again, shall we say, that we have a chunk of people, it'll hit some stopping points because we have a chunk of people who really are vaccinated. I really would be saddened to see that we had to see more communities see sickness before those communities got vaccinated. I worry about that. And we do know it's the individual who's going to get sick.
Right. And then the booster.
The booster. So the first thing I think is really important, and that is if you get your 2 prime shots today, you're protected today. And that I think has been miscommunicated. People are saying, well, if I'm going to need to get it again, why don't I just wait? Because the answer is you're protected today, and we need you to be protected today. Most of the studies only go out to 6 months. And so we're saying 6 months for now, but we don't know. It could be 9, it could be 12, it could be 24. The bottom line is we want to be ready. And importantly, we want to be ready because the first group of people we vaccinated were in fact our most vulnerable, our elderly, our people in the long-term care facilities, the one who may not have had as robust an immune response to start with. So if they were going to sort of have a waning immune response, the people we vaccinated first might be the first to show that. There are all sorts of scientific questions that we are working to answer in collaboration with NIH and BARDA and with regard to when should they be given, in whom should they be given, what vaccine should be given. Should we think about something tailored to a variant? And then also, how can we cross-vaccinate? If I got Pfizer, can I get Moderna the next time? Which obviously would make the logistics of this much, much easier. So all of those scientific questions are actively being worked on right now with the goal of being ready when we need it. Not saying it's going to be in 6 months, but we want to be ready when we need it.
Yeah. So I said I only had one more, but I have 2 more questions. So first is the recent guidelines and guidance around mask wearing. Obviously, as you know, it wasn't as straightforward as many people may have wanted, and we are existing in a world of vaccinated and unvaccinated people. And even if all adults are vaccinated, we still live in a world where there are children who can't yet get vaccinated. So it would be great to hear from your perspective, why those guidelines, and then how do you help people understand in this state that we're in of vaccinated, unvaccinated people, how they kind of use their common sense, if you will, to interpret some of these things. Because I think, as a public health agency, you think of it from a population perspective, but then individuals need to interpret that for their own sake.
Thank you for the opportunity to expand on this, because many people have said, we didn't hear the science. There is science. So there were 3 major factors that went into that guidance. One is cases were coming down and people were doing what they wanted to do. And so they needed some scientific rationale, because people were asking questions. Well, there's no cases here anymore. And I have a lot of people vaccinated. 2 is it came to a point that anybody who wanted a vaccine could get it. We didn't want to release this guidance when some people were getting it and some people didn't have the opportunity to. So those 2 things happened to happen at around the same time. And then the third was evolving science. And the evolving science occurred in 3 different areas. One is we had continued effectiveness studies. That is, the vaccine was working just as well in the community, in the real world, as it did in the clinical trials. That wasn't obvious. We weren't certain that was going to happen. And it did over and over again, over 90%, 95% effectiveness when we used it in the real world. 2 was By the time we were using it in the real world, we had 74% of the samples being 117, and we needed to make sure that it was working in 117. And so that was happening. And then third, something they didn't convey in didn't study in the clinical trials was, is the virus transmissible if you are vaccinated? Could you carry asymptomatic infection, and would you potentially give it to somebody else? And emerging data suggested that that was less likely as well. So in the 2 weeks prior to our guidance, we had all 3 areas of science that really were emerging to say it really is safe for the vaccinated person to take off their mask. We knew for numerous reasons that this was going to be a challenge. The federal government was never going to be the owner of validation plans. And so whenever it is that we did this, this was going to be a challenge because there is never a central validation plan for vaccination. And 2 is, for 16 months, we've been telling people to wear masks. And how do we then roll back and say, actually, now it's okay if you're vaccinated, if you don't?
Yeah, I tell you, it's been an interesting the last month or so as we all kind of emerge from this hypervigilance to figuring out what our comfort level is. So really appreciate you kind of explaining the logic and consistently being good about trying to communicate at a level that people can actually understand that relates them. So my last question is just, you weren't at the helm of CDC when this started, and there probably are things that you might have done differently. But beyond just CDC, if you were to say, because we will face something like this again, what are the lessons that we should be learning from this so that we are better prepared the next time?
Maybe I'll put that in sort of 4 big buckets. One, and our public health infrastructure was never equipped to handle this. I like to say public health is working for you when you don't know that it's working for you, right? So while we've had COVID, we also have had the cases of Legionnaires and cases of measles and cases of salmonella, and nobody had to hear about it because they've been handled, right? We didn't have the public health workforce. In the last 10 years with, Ebola, Zika, H1N1, and COVID, we've lost 60,000 public health jobs in this country. 60,000. We were not upskilled. We were not trained. We did not have community health workers that came from the communities they needed to serve. So we really need a workforce. We didn't have a data plan. We didn't have interoperability of data. We didn't have capacity to share data. We didn't have capacity to look at race and ethnicity data for all of our tests. So the data and data was coming into health departments through fax machines. 250,000 tests a day coming into health departments through fax machines. We never had the capacity for that. And then, of course, public health labs. Never equipped to handle the kind of thing that they had to handle through this in terms, and folks who've been doing this work clinically know early on you had 50 patients and all of them needed a COVID test and there were 2, right? So how do we scale up public health labs, genomic surveillance, wastewater surveillance? All of this has emerged through the process of what we've done here with COVID, and all of it needs to continue. We have this history in public health resources of having the disaster go away and then the funding goes away. And we can't be doing that. I've done 6 congressional hearings since I started, and all of them I have said this part of the challenge here was to a frail public health infrastructure. The final thing I'll note with regard to that is we could have easily predicted that disease, like nearly other, was going to hit our vulnerable communities. It was obvious to everybody who studied and worked in infectious disease. It came through cruises and planes, and it landed in vulnerable communities. And until we have access to health care for those communities, we will not have health across this country.
Well, thank you. And on that last point, also thank you for your role in really declaring racism as a public health threat and acknowledging the impact that race and racism have had in how we address these issues of equity. But more importantly, or as importantly, just thank you for your passion, your commitment, all the expertise that you bring to your role, and just your willingness to use plain spoken common sense to reach everyday people with a public health message. So thank you so much for all you do, and continue doing the great job that you're doing.
Thank you so much. Delighted to be with you.